This week on Surfing the NASH Tsunami.
And I think coming from that angle, there was a group of collaborators that got together and asked the question, how can we improve patient identification? It took two big databases available in the US. One is the NIDDK, National Database on Diabetes and Kidney Diseases. And it's a longitudinal registry that actually contains liver histology and patients characterized with liver histology. The second database we used is the Optum Electronic Healthcare Record database, again, which is a large adult patient database in the US.
A tool like this, where the majority of the patients did not have a liver biopsy and really identified as being at risk for NASH or likely to have NASH, will provide additional data that will help us to identify those patients who truly are at higher risk.
Every week, a global community of fatty liver disease stakeholders comes together to explore the most important challenges in diagnosing, treating, and developing medications for patients with fatty liver diseases. Join hepatology researcher and key opinion leader Professor Jörn Schattenberg, liver wellness advocate Louise Campbell, pricing and forecasting guru Roger Green, and this week's guest, hepatology researcher and key opinion leader Dr. Kris Kowdley, as they discuss Professor Schattenberg's recent paper on machine learning and NASH diagnosis this week on the Surfing the NASH Tsunami podcast.
For everyone with an interest in NASH, or more broadly, fatty liver disease, Surf's Up. Season 2, Episode 20 of Surfing the NASH Tsunami starts now. Although we've decided not to make a big fuss about it, this is a historic week for Surfing the NASH Tsunami. Last Friday marked the first anniversary of posting our first episode. So in terms of posting episodes, year 2, season 2 started a long time ago, year 2 starts today. We're not making a fuss about this for two reasons. Number one, there's so much to discuss between the topics today and upcoming events that I couldn't find a week where it made sense to focus mostly on the anniversary. Number two, more important, this podcast is about you, not us. We'll take our feel-good time in private, and we'll devote our airtime last week, today, and next week to bring you episodes that matter to you and to the fatty liver community. So what else makes today special? This is the second of 3 straight Jörn Schattenberg appearances, making him the periodic guest with the most consecutive appearances in the history of this podcast. Congratulations, Jörn. Stephen is away again in the middle of a 5 or 6 week streak that's going to be the most weeks away at a time by a permanent panel member. But he is recording an episode Monday you'll hear sometime in May. And we're fortunate to have our good friend Kris Kowdley with us once again. Kris, thanks for joining us. How are you today?
I'm just fine. Thank you for inviting me.
Well, we're delighted to have you with us. Let's move on to the icebreaker. Just one good thing of the past week. Let's make these professional bests. Brave one, go first.
I'll go first. I had the honor of participating in Liver Connect, which is the inaugural CME conference put on by Chronic Liver Disease Foundation, and had a chance to meet you face-to-face, Roger. And what was lovely about this was it was the first time that many of us had traveled since early March, and it was just so refreshing to meet old friends, to meet face-to-face after being in Zoom meetings for over a year, and to really recognize that direct interaction among friends and colleagues is something that cannot be taken for granted or ever replaced. And thanks to our vaccination efforts, almost all of us were vaccinated. So to me, that's something to be very grateful for.
Boy, I couldn't agree more, and congratulations on a fantastic presentation as well.
I had the pleasure of rescanning a patient who's changed their behavior following a scan I did on them a couple of years ago. I was desperate to be scanned, has lost over 17 kilos and has gone from fatty liver disease to a normal liver, all from the moment of teaching on a FibroScan done previously. So he's maintained his weight loss. He's been desperate to have that second scan, but because he doesn't meet the pathway of a normal stiffness, just high fat, to be rescanned in 5 years, he found me. So it was reassuring to actually see all of the hard work that he'd done, and rewarding.
That's fantastic, and aligns, I think, really well with your frequent statement that when people see a FibroScan number, it wakes them up in ways that other things might not. So that's great. Jörn?
I'm a little jealous when I hear Kris report from his face-to-face meetings, because I hadn't had those yet here. And congrats, Kris, for being invited and giving a great speech there. I'm really looking forward to that. For us, it was the weeks of Internal Medicine Association meeting in Germany, which is a big meeting. Internal medicine specialists from all areas are meeting online these days, but I was very fortunate to be invited speaking on NASH. NASH, and I think this is a good sign, bringing it up more, beyond the liver or gastro arena, and actually engage with cardiologists, pulmonologists, nephrologists on this frequent problem. This was a personal highlight for me. Beyond that, it's a week of teaching here too. Students are back in virtual class, and a lot of meetings on teaching duties, and that's made it a particular tense week.
Jörn, this is the second time in 3 months you've talked about fatty liver breaking through in the German culture in a way it hadn't before. You talked about news stories back in December, I remember, and now talking to the larger internal medicine community. That all sounds great. Very, very exciting. Okay, so my good news is also CLDF, the meeting in Scottsdale. First of all, I got to see people I'd never met face-to-face, Kris being one example of that, but hardly the only one, and got to see some great presentations. Kris's presentation, Stephen, among people you'll know on the podcast, Stephen had a presentation, Mazen Noureddin had a presentation, Mary Ranella had a presentation. I missed Wednesday's lead-in day, which was the International NASH Symposium, where Naeem Al-Khoury and Manal Abdelmalek made presentations. I think that's it for past guests of the podcast, but if I'm leaving anybody out, please forgive me. I had come to believe that we can all do business on Zoom or Google Meet or pick the one of your choice. But I'm with you, Kris. The energy in that place and the energy of being face-to-face with people you'd known for a while. In my case, some that I'd known for years but hadn't seen in a while. In some cases, like you, people I'd never met face-to-face, was just extraordinary. And I'm hopeful that Jörn, you and Louise get to have that experience before too long, because it's really pretty special. Okay, let's go on to today's episode. By now, if you've been with us for a while, you know that most of the leading key opinion leaders, and certainly the folks who are good enough to come on Surfing NASH, each has several principal areas of research. And today, Jörn will be talking about one of his that I don't think we've brought up yet, machine learning for the purposes of prediction. Jörn's been speaking and publishing on this issue for several years. Last month, the Journal of the American Medical Informatics Association published a paper on which he was last author titled Development of a Novel Machine Learning Model to Predict Presence of Non-Alcoholic Steatohepatitis. It presents the NASHmap model, which is unique for reasons Jörn will explain as he discusses the paper. So Jörn, first, just congratulations to you and your colleagues. What a great piece of work.
Thank you, Roger, and thank you for giving me the opportunity to discuss it online here with you and really break it down, what it could mean in terms of patient identification. It's an interesting approach and a research that I stumbled in by chance, but I guess today the technology advancement is such an omnipresent situation that it's just at the top of your head, or it's something that you'll end up thinking, how can I apply these powerful machine learning techniques, artificial intelligence, to solve a problem in clinical practice? And I'll just go right on and dig in and say that from my perspective, one of the major issues in the field, and I highlighted that I talked to medical professionals and that it was up in newspapers still, this disease being highly prevalent is not well recognized. And many clinicians are missing the disease. And also from a sponsor's perspective, if sponsors come to me and say, where do you find your patients? How can we identify patients? There is still a lot of unmet need. Coming from that angle, the group of collaborators got together and asked the question, how can we improve patient identification? And the way it was done here in this paper, and this is pretty much the development of the analytical tool, the machine learning algorithm, as you like. It has some clinical data in it, but hopefully there will be a publication that details the entire clinical aspects in a little bit more depth. But looking at how the model was developed, the unique thing is it took two big databases available in the US. One is the NIDDK, National Database on Diabetes and Kidney Diseases, and it's a longitudinal registry that actually contains liver histology and patients characterized with liver histology. It has a lot of additional data points, and it has an in-depth information that you can actually exclude other liver diseases and really come up with a NASH cohort. The second database we used in the end after developing the model to train it and validate it is the Optum Electronic Healthcare Record database, again, which is a large adult patient database in the US, which most of you are comfortable with, and it contains just a tremendous amount of data. And the way the paper is built up and the way we followed our research questions is that we took the NIDDK model first and built a machine learning model by selecting individual features from within the NIDDK database to then predict the outcome of a patient having NASH versus not having NASH. This is at the heart of the model, and I'll give you a little bit more insight, but maybe stop here for a second because I've been talking a lot, and just following up we can decide whether this is the right question to be asked or maybe something that you'd like to feedback at this point.
Thanks for a fantastic opening and introduction to the paper, and really an exceptional piece of work. Stephen sometimes advocates, and independently I do as well, a mode of telling a story called what, so what, and now what. What fundamentally would be in this case, so what is the paper, what does it do, what does it show? So what would be, why does that that matter? And now what would be, with this information in place, how can the world change? And I think that might be a helpful way to discuss. Kris, Louise, have at it.
Yeah, so Jörn, congratulations on this really important study. What I really liked about the study was that you had a training set and a validation set in both cohorts. And obviously, we will know that the NIDDK cohort is much more likely to be enriched with patients with NASH and probably more carefully phenotyped since it comes from the National Institute of Digestive Diabetes and Kidney Disease, where they're experts, whereas the other population health database would be more likely to have a more heterogeneous population. One question I had was, it looked like when you identify the patients that had a diagnosis of NASH but also had a liver biopsy in the Optum database, they were much fewer than the patients who had a diagnosis of NASH but not a biopsy. Can you expand a little on that and how you think that might have either weakened your findings or maybe made it more generalizable to the broader population?
Yeah, that's a very important point in it, and it goes into how the validation set was then used to explore the algorithm. Optum has something like 15 million records we were able to access, and we didn't discuss how we built the score yet. However, it's based in its most commonly used form on 14 variables that it needs. So we had 3 million data sets in the larger Optum electronic healthcare records with those 14 features available, and actually 70,000 patients with an ICD-10 code of NASH. Within those NASH-coded ones, it was 23,000 that had those 14 features, but only 1,000 with liver histology. So it's a 23-fold difference, as you highlighted, patients that do actually have a biopsy in Optum compared to the coding of NASH. I think it's something we do see in database research very frequently. While there is a strong undercoding likely to occur, those patients that are coded are more phenotypically likely to have NASH, in my personal experience. And then a very small subset actually went on to get biopsy. How did that influence the results? I didn't give you too much details in the test accuracy quite yet, but I can say that they were actually very similar between the NIDDK with a very well phenotyped cohort and the Optum electronic healthcare records, which with an AOC of 0.82 in the NIDDK and 0.79 in Optum. And that told us that despite all gray areas that are there in Optum, that algorithm that was built in the NIDDK was pretty robust. And at the end of the day, actually applying the 14-feature model to the large Optum electronic healthcare records, we identified an additional 900,000 patients with probable NASH that are not coded compared to the 23,000 that are actually coded. This is where the power of the algorithm then comes in. You have large databases, or let's say electronic medical records, and you can run that data, you can run the algorithm and identify patients with probable NASH. One very important point here, it's not diagnosing NASH, and I think Kris would have asked that in a follow-up question. Of course, I don't know that the patient has NASH, but it's a patient that has a very high pretest probability, so it's an enrichment tool that you will need to then guide on additional diagnostics and potentially follow-up.
My one follow-up question is, I think based on this, you have a 1 out of 20 patients in whom you suspected NASH actually had a biopsy, but on the other hand, the characteristics of the 19 out of the 20 that did not have a biopsy was very similar to the 1 out of 20 that had a biopsy. And you can look at it and say, well, that's a limitation or a weakness of the data set, but you can also look at it and say, in the real world, it's very likely that biopsies are going to be done in a minority of patients who likely have NASH. To me, it makes the data more robust and in some way more applicable to the general population, in that the presence or absence of a liver biopsy did not necessarily change performance characteristics of identifying likely NASH.
Absolutely, that's correct, and I agree that it tells us that the AOC between those two data sets is not particularly different. And I do see, as you highlighted, that again many people will fortunately not need a liver biopsy and still have NASH. So that's where the algorithm can help us. And going back and starting out, the machine learning algorithm we called NASHmap was developed in the NIDDK with 704 patients that had histologically confirmed NASH, respectively histologically confirmed non-NASH. And it was split in a training and a testing set 2-to-1. And what the machine does is it takes all available data points and knows the outcome. So it compares the NASH versus the non-NASH case. This was a decision tree building model, and it takes one variable, splits all the NASH versus the non-NASH cases, and then adds an additional variable to separate them more precisely. Now, when I looked at how the model was actually built and how it separates cases, the first thing that struck me is that it doesn't take cutoffs that I would usually consider clinically relevant in clinics. For example, the top feature that came out in the model was HbA1c, but it didn't split all patients according to an HbA1c of 6.5 and higher, indicating of type 2 diabetes, or lower. It took a cutoff of 8.2 at one point, and then it ran additional features underneath that in the same tree, and it looked at AST and ALT and used different cutoffs to separate those. Now, this is one tree that was built. That data set was then again entered into a second tree where the algorithm again split the cases NASH and non-NASH and used those parameters to separate them. In that second tree, they could actually use a different cutoff of HbA1c again. This is where the strength of the machine learning model came in, that it's capable to separate individual numbers to a much higher extent to dissect patients with NASH and non-NASH than a clinician would be able to. And most of the time, I probably use 5 or 6 phenotypic features, including transaminases, obesity, type 2 diabetes, to say this patient has probable NASH. We're probably not too bad with some experience with that, but again, the machine learning model is available to then non-expert and outside of specialists' offices, and I think this is the real advantage where it kicks in with a potential. We've used those 14 feature model to predict, and again, in the training set, the AOC, I think I mentioned that was 0.82, and separating those NASH from non-NASH cases. To be able to use a slightly slimmed down data set, we also developed the 5-feature model. This can be important if you have data sets that do not have all these features available. Please go visit the paper to get all 14 of them. But for the 5 features, I'd like to say it's HbA1c, AST, ALT, interestingly, total protein, and triglycerides. And I think with these 2 models, which most databases have, or electronic medical records, you're able to apply this tool and actually enrich your population, identify unidentified patients, or in large data set do research with this.
I found it a fascinating read, and I found it very interesting. I think when you replied earlier, you hit the point. It's not the enriched populations we want to find and the already diagnosed, it's actually the undiagnosed. Now, you mentioned that an additional 900,000 subjects were sort of identified that had a high probability of having NAFLD or NASH. Does the model give us an opportunity to look at cost modelling on those 900,000 at all? I think we've discussed it a lot on the podcast recently with Marthan, and I can just hear breaths being released in the NHS if we suddenly went to locate 900,000 and what the costs would be from that sort of side. So I think finding the patients is fantastic. People get concerned about that, but being able to look at the enriched population we can gauge. So this being added to the AI, because I found its ability to diagnose was very good.
Thank you, Louise, and point well taken. If you order additional tests on 900,000 patients at a moment in time, it's going to cause incremental costs, and for sure you want to say that there's a benefit for the patient in ordering that additional test. So it has to have a consequence, I think, and that brings it back to the context of use. Where would you want to use that, and for what reason? I think you can look at that from different perspectives, and different contexts of use seem probable. I do see it right now as a potential tool for clinical trial enrichment, where you say, I have a physician that's highly experienced diabetologist, never done studies in NASH, and we're really looking for somebody who contributes to our phase 3 trial. And if you provide him with such a tool, and he has an electronic healthcare record system, he can probably identify a fair number of patients that do qualify for additional testing to then be offered potentially enrollment in a clinical trial. So this is a special situation that we are now at. In the future, hopefully we'll have therapeutics that show a benefit for the patient, and I think then the whole story with regards to cost effectiveness of additional testing could be something you're discussing in a healthcare system. As you are highlighting it now, and importantly, this algorithm is not identifying patients with advanced fibrosis to NASH, which are close to a relevant liver endpoint that needs immediate treatment. It identifies patients with NASH or probable NASH. And I think for those patients, I cannot advocate at this stage that we have to spend a lot of money diagnosing all these patients, potentially with invasive technologies, to then not be able to offer anything to them. So that's an important point.
Can I also just ask, was there any FibroScan data available on these patients? Was there any other non-invasive technology apart from biopsy that could have been used for a real-world extrapolation in these patients?
No, it was not. I can say that the NIDDK data span was 2002 to 2006, and the Optum was covering 2007 to 2017. So that's 10 years. And for sure, there was some FibroScan data towards the end, but it wasn't available on this one.
Louise, I went to the same place you did. In fact, where I went specifically was back 3 weeks in the podcast. Jörn, I don't think you were with us that week, but Ian Rowe was on talking about some of what they've learned in Leeds. And what they've learned is that a lot of the seeming intermediate tests that you would intuitively think might save you money don't. So they took a look at the value of ELF, for example, going FIB4 ELF FibroScan versus simply going FIB4 to FibroScan. And they looked separately at ultrasound the same way. And in both cases came to the conclusion that once you've got a decent reason to believe that the patient has, in this case, NAFLD, I think NASH even more so, you might go straight to elastography, confirm the case or not on KPAs, and know what needs to get treated or not. The logic being that where you got a positive test, that wasn't a surprise, and where you got a negative test, but other markers were strong enough, you tended to discount the negative test and go to FibroScan to confirm it anyway. So then why not just go straight to FibroScan? When I read this, and then when I heard Louise's question, even more so, I believe that over time, an algorithm like this should be the way that we screen who goes straight to elastography or some kind of more quantitative, more confirmatory measure, short of biopsy, using NITs to their best outcome. Does that make sense?
To me, it makes a lot of sense. And again, it's not capable of identifying patients with fibrosis. And I do see the FibroScan as absolute strength to rule out cirrhosis and identifying patients. And the NASHmap will highlight you patients with probable NASH. So I would think, yes, because you do spend money on a FibroScan. And again, it might not be needed in a setting where you have a hepatologist or somebody experienced in diagnosing liver disease is absolutely required. But it's a support tool that could run in the back end of an electronic healthcare record system of a physician that hasn't a lot of experience in hepatology and support them. And there are areas in Germany, I'm sure there's in the US, where there's a lot of physicians retiring, no access to medical, particularly not to hepatology care. And I think in those settings, it can help you funnel patients' guide on their management.
Jörn, I have a couple of questions. The first is we know that ethnicity or race is a very big driver of likelihood of finding NASH in an at-risk patient. How was that accounted for in the Optum database, and how do you utilize that in a model of this sort? And then the second question, which really is something that I've struggled with for quite a long time, is that when you develop these non-invasive tools to identify patients at risk for a particular disease, the performance characteristics of the test is very much dependent on the prevalence of the disease in the population that you're studying. So, for example, I feel pretty confident that in the NIDDK cohort, the prevalence of NASH, and in fact it was, I think 2/3 of the patients in the NIDDK cohort actually had NASH. So what I struggle with whether it's FIB4 or other non-proprietary tests, or even if it's something like elastography, etc., how are these tests going to hold up when we start to broadcast them in large EHRs and with low prevalences of disease? Will they still hold up, and how do we fine-tune that to make them more useful?
Yeah, very important points, Kris. And the genetic aspects I'm not aware how it is captured in NIDDK, but it didn't come up as a signal for sure. It wasn't included in the analysis, so it was not accounted for in this algorithm. And it's nothing we explored in depth in the paper, so whether a genetic background is a contributor here. So that's not available in this. The second point is well taken, and the pretest probability does influence the performance characteristics. Absolutely agree. I'd love to wrap my head or that algorithm around a database with a much lower pretest probability, different settings. So if you're listening in, you're interested, feel free to reach out. What I can say at this point is that the performance between patients with type 2 diabetes and those without type 2 diabetes wasn't much different. And we've actually subsequently looked into a study database for diabetes trials. So this is all diabetes patients. And here the algorithm actually identified patients that were more insulin resistant in a group with all insulin resistant and identified them as probable NASH. So I think there is certain tweaks that these 14 variables have to move or identify patients even outside of obvious high-risk constellations. And I mentioned the 5 features already. If you expand it to the 14 features, you'll find that height, platelets, and hematocrit, and as 14th variable, the gender is coming in. So I think it has some tools to even identify patients in lower risk populations.
Jörn, this might be the weakest question of the afternoon, but I was struck by some of the variables that were lower on the gradient. And kind of specifically, I was wondering if there was a hypothesis about the role that height played. Gender is another independent variable further down the list, and BMI is there also, which means height has to have some kind of independent value, and I couldn't figure out exactly how that would piece together. You know the whole data set, I'm wondering.
We've discussed it at length too. I mean, height is a variable within BMI, so does it make sense to take that variable twice? That was my first question when I saw that. But in the end, the machine put that out, and it has additional value if you put this in. We actually tested the algorithm and tried to reduce it to 5 features. If you bring it up to 24 features, it doesn't become much better. So the 14 features is the breakpoint where it was good. How does the height come in? It's just, I think it stresses the importance of body composition, and BMI and height showing up here shows us that this is something that's just very closely related with the probability of having NASH.
First of all, if you're in multivariate stats, in my background. So that piece of the methodology I was a huge fan of. We did a bunch of bootstrapping and bagging in our business, and we're just starting to flirt with XGBoost when I decided I didn't want to be in marketing research anymore. So the methodology made tons of sense to me, and it's clear that height is an independent variable. I mean, you can take a look at down at the bottom where the relative strength of hypertension is 16% or gender is 12%, and you can say, gee, that's not adding a ton. But the relative strength of height, certainly independent of BMI, is powerful enough. So it would be interesting to know if there are other correlates to height outside of this model that might shed further light onto why that matters. So I was also struck by the idea that in the 14 feature model, AST was number 2, ALT was number 3, and the AST-ALT ratio was number 5. I'm sure you dug into that one because those are really powerful predictors. What was the independent value of the ratio aside from the value of the individual scores, or why were the individual scores so high given the predictive power of the ratio?
I've tried to discuss this biologically. In the end, it's the machine taking events, looking at events and selecting which variables are most robustly correlated with that. And why does AST pop up before ALT? It's interesting because we think NASH is more inflammatory. You'd be looking at ALT, AST-ALT ratio goes towards cirrhosis, but we're not aiming to detect cirrhosis here. I don't have the full final answer. It's just, I think it's plausible we're talking about an inflammatory liver disease to have these tests up very high on the list.
I'm sure that's right. I'm a big believer that the statistics tell you what they tell you, and one of the things about machine learning is that it draws patterns that you intuitively wouldn't think were right, as you just pointed out about AST and ALT. The fact that they're both so high up says to me, I don't really care which one's higher. It might have something to do with diabetics, since HbA1c is the first one on the list. But I guess I'm wondering, how much can we learn about the liver or theories about the liver by looking at this pattern and also understanding what variables weren't included or did not make the cut that would tell us either things that we didn't know previously or give us different ways of looking at things?
Yeah, well, the one that struck me again very prominently is total protein. It's up in the list in number 4 in that importance rank. Again, you highlighted it in the paper. There's a table where you can see the relative contribution or the relative feature importance, and total protein has 71%. And total protein is probably one of those values that's not even routinely always measured in all liver clinics, but it's about nutrition and it's about liver function and biological. There are many plausible ways how I could link this to the disease inflammatory phenotype or fibrotic phenotype. And this is the only downside. Maybe I have to understand machine learning a little better, but to a certain extent, it's a black box mechanism where it takes the available data and gives you an output. And then you can delete certain valuables and see how well it does, and then still separating those cases. But I'm not convinced that this time that it will tell us something about the disease. It's more, it's also influenced about which features are captured in the data set. And I think the most important learning for me was the models are only as good as the data that goes into the models.
That's been the history of EHR. I think that's right.
I was just thinking when you were talking about BMI and height, and then what Kris was saying, that if we take this data set and we put it in an Asian population, BMI is different. And the definition of high BMI is different. And height, often they have a BMI and they're shorter, they're not as tall. So again, in an enriched demographic where they may have a very high probability of having NAFLD and NASH, BMI may not be as indicative in that population. And it's generally a poor marker. We had an article out in the press last week that BMI encourages eating disorder because people actually don't trust it, they don't believe it, and everybody's body composition is different. So maybe more enriched populations. And we don't take the best data in hospitals, we take general data BMI being one of them, rather than a body composition data set in high-risk populations. So I just wondered, that draws in Kris's question about ethnicity.
And it's an important one, and you don't let me get off the hook here. So I went into the supplementary materials and had to look it up myself. And actually, with there, we were saying that, or we identified it's 70% non-Hispanic in the NASH and 30% Hispanic. And if I look into the breakdown of races, it's only 3% African American, 4% Indian American, 5% Asian, 80% white. So this is something that will not allow for in-depth analysis in different ethnicities. Again, I think you'd have to go there and look at those data and see how a model that's built in a U.S. population like this would perform. And even in Germany, I haven't done it yet. We'll have to study that.
That's a good point. Jörn, one of the things I take out of this, though, is that it's possible to build a model, even in an enriched data set. If you can get here over time, you can start to figure out things like, if you can get large enough subpopulations, you can figure out what does and doesn't work in the subpopulations. Machine learning isn't, well, it is what it is. As you say, it takes things out of a black box, but usually variables that are there represent something you understand, right? So HbA1c would be about insulin resistance. AST, ALT in the ratio would be about the liver. Protein would be about the diet. BMI would be about obesity. You can go down and you can say, okay, I understand what most of these things represent and why this measure represents that as compared to a different measure. Was there anything you would have expected to see in this when you started that isn't here or isn't really represented by what is here?
The age, I guess, is something that I normally consider important in my clinics, but it's multidimensional. I mean, that goes into how intensively do I counsel the patient and so on. I think age is a risk factor for NASH. It didn't show up here. I don't remember where it knocked out. I think it was in the first 24th, but that's something that in clinics is very important to me and that the machine didn't come up with here.
That in itself is interesting because we have a preconceived idea that the older you get, the greater your risk because of that longevity. But we're seeing now more and more children and adolescents with fatty liver disease. And I think I come across people regularly that go to the gym that have blood tests that suggest fatty liver disease all over them, look good on the outside, but eat a really poor diet. And you can measure it on the inside. So that preconception, and I think this is where a lot of primary care physicians, a lot of other physicians come into, I know what I'm looking for before I find it. And that happens in lots of areas of liver disease, whether it's viral hepatitis, people have a fixed idea of demographics. So it is interesting that age didn't come up because, of course, machines aren't biased in that way. They just take the data.
Yeah, and I guess the second thing you could discuss that there should be more lipids in there. I mean, there's only the triglycerides that made the cut and no HDL, LDL, or cholesterol. And I think, does that mean that metabolism is, in this context, not as important? I think if you ask me what do I learn from the model, it's tweaked a little bit towards, again, that nutrition, many liver aspects, diabetes as the highly ranked, or the HbA1c. But then again, it's not only about diabetes. It works as well in non-diabetic patients. And it's not always choosing the same cutoff. As I tried to explain in the tree building concept, it uses different cutoffs and much more differentiated than as a clinician when I look at it.
Do you think if these models, when they go out, if this can be used in primary care and throughout those data sets, even if it doesn't pick up NAFLD and NASH, even though it's got that high probability, because you excluded alcohol and all previous other diagnoses of liver disease, if this was put into a general population, would you expect to see it pick up considerably more liver disease per se? I suspect it would pick up your alcohol or average to moderately high alcohol intake because, again, it's got a fatty liver profile, they're high risk of diabetes, and their lipids are out. And they tend to have higher BMI, some of them. Do you think it would enrich our skill at diagnosing all liver diseases?
It was specifically built in the NASH population. We're well aware that in everyday life there is a certain degree of overlap. Once you're driven more towards alcoholic liver disease, your phenotype becomes very different with malnutrition. So I think it will not look at the advanced, truly alcohol-driven liver disease patients. But in the overlap population, it could be. And again, we discussed cost effectiveness. I mean, if you have a primary care physician and the patient is flagged, I mean, the first step could be to just recommend something to watch diet more closely or something like that. This could be a very simple lifestyle advice that somebody gives the patient saying, hey, here's a flag up. Doesn't mean you're sick, but you're in an at-risk liver disease category. So better watch your diet for a half a year and we'll come back and do some checks.
A couple of things that caught my attention also, which I think will make it easier for clinicians. This similarity, if you will, of the two different cohorts suggests to me that at first glance you may think that the NIDDK cohort may be more selectively ruled out for alcohol as a cofactor, not necessarily alcoholic liver disease, but certainly the combined alcohol, metabolic liver disease cohort. But the fact that this was really not a confounder when you look at this large Optum database, it suggests that maybe clinicians are not so bad at separating patients that have NASH or NAFL from patients who have alcohol as a big component of their disease. And the second thing that I think is interesting about the AST being hierarchically such an important variable is that, it provides a little bit more credence to the FAST score and using AST along with elastography with FibroScan. And I think that'll make advocates of the FAST score a little bit happier. I wonder if Louise has some comment about that, but those are my observations. I think this suggests to me that, most metabolic liver disease that's related to fat is in fact probably just related to fatty liver.
So, Louise, I want to use Kris's invitation to you as a transition into the third part of this discussion, which is now what? And I think the now what falls into two categories. One is, as Stephen is fond of saying, great papers yield tons of many, many, many lines of research. And Jörn, I can see 5 or 6 coming out of this, and I'm not even very good at that. And then second, there's the question that Kris asked you, Louise, which is, all right, fine, if we elevate the value of AST, we make FAST look better. As an advocate and as a treater, a line treater, what do you think this study pretends for you and the kinds of things you do with Taoism and patients like that?
Well, I think it comes back to Jörn's point at the beginning. I think it's about clinical trials, and it's about finding the best patient at the right time for clinical trials. I've seen a number of people that I'm scanning for a trial at the moment, but I'm seeing very much the COVID effect, where a patient had said to me, I did his scan, and I asked him, had he made any changes to his diet? And he said no. And I said, are you sure about that? And he said, well, if I think about it, I'm having a little bit more Deliveroo than I was, maybe once a week. And then a couple of minutes later, it was maybe twice a week. Oh, and my children have introduced me to a brioche chicken burger bun every lunchtime. And in 4 months, he had sent his liver fat up from about 269 to 333. So we're probably going to see a rise in his AST. So I think being able to do that and pick out these right people for clinical trials who don't need a liver biopsy, I think in the COVID and post-COVID era is going to be really, really difficult, because I think we're going to have to really spend taking attention, that finer detail. And I think this sort of research allows us to say that it is of extreme value. So if we do couple it with elastography is good in its own environment, but the more accurate we can make it, these are what we can also use in the real world. I think we can't use MRI PDFF for every patient in the real world. We can't biopsy every patient, but actually a lot of endocrinology clinics have FibroScan. They can do FAST. They can actually enrich populations available for clinical trials from lots of diverse areas now. We don't see enough people in clinical trials with fatty liver disease, but we certainly don't see enough people of different ethnicities. And we've discussed it before, that the majority of patients in clinical trials, non-ethnic, they're white, Caucasian, from a higher socioeconomic background and educational background. That throws studies, but we can put FibroScan into Hispanic populations. We can really look, and it's data sets like this and AI studies that allow us to utilize the non-invasive toys that we've got in the real world. And it makes it relevant to patients because they can see it, they can relate to it. And I talk a lot about how a patient relates to the test that you're giving them. They don't relate to an algorithm. But as Jörn said, if you can use this in your clinics to say, actually, you might have to watch your diet for a little while, that'll engage somebody for a period of time. They also want to see the proof. And it's not a mathematical algorithm, but for clinical trials, we do need to pick the right patients at the highest probability. And this sort of work really lends to that. There shouldn't really be a trial, and Stephen said it, that doesn't use elastography to screen. And I'd argue there shouldn't be any clinical trial that's not ruling out fatty liver disease, whether it's cardiology, whether or not it's rheumatology. I read a paper this week about normal ejection fraction in a significant amount of patients with liver disease. So it's a real problem, and we need to screen out liver disease. And these sort of pieces of work are absolutely vital in that.
I think there are several really useful insights that come out of the study. The first is, as I alluded to at the very beginning, the fact that you can use a tool like this where the majority of the patients did not have a liver biopsy and really identified as being at risk for NASH or likely to have NASH will provide additional data that will help us to identify those patients who truly are at higher risk. I think this type of data obviously needs to be reproduced from another large data set of well-characterized patients with a phenotype and then broadened out to other databases, whether it's from the VA or other systems databases to see whether it's durable and robust in other populations. I also think that the fact that there's not a lot of discussion about ethnicity or race or even alcohol consumption in this type of database, but still producing a useful tool will allow us to identify those patients at greater risk without getting distracted into other types of risk behaviors that clearly need to be modified, but may not necessarily be the root cause of the problem. And finally, I think this will be a huge tool that will change the thinking of our endocrine colleagues and our primary care colleagues who historically still will only think about liver disease in a patient with an elevated ALT. And I think that broadening the scope to focus first and foremost on insulin resistance, followed by features of necroinflammation, and then followed by tools that measure nutritional status, in some ways will change our thinking about how we identify patients who are at risk for NASH and really bring the focus back to the root cause, which is, visceral fat, peripheral lipolysis, and insulin resistance as being the greatest first hits, if you will, that initiate this cascade.
Thanks, Kris. Jörn, you want to comment on that? And then I have a couple of questions.
No, I think, Kris, thank you for summarizing it. Many things I could have only echoed. I agree, and I'm happy you pointed these out. To follow up on your thoughts on identification of patients with predominantly alcoholic liver disease. I mean, you've been in this field much longer than I have, and you've seen your share. But I think personally, I have become fairly comfortable in identifying patients that have a predominant alcoholic liver disease. There's some that you don't get your head around. But I think physicians in general there's a whole discussion of how can you exclude it. I think physicians are fairly good at that.
Jörn, I had a question. I'm amazed I didn't think of until 3 minutes ago. We have a bunch of tests, FibroScan, for example, that are very good in negative predictive value, but not so good in positive predictive value. From the way that you've teed up the paper, it's pretty good at positive predictive value, which would say if you lay it up next to elastography, for example, you have a package that does a decent job on both sides of that equation.
Absolutely, and something I haven't discussed yet, and I'm happy you mentioned it. It's a little different setup. It's not designed to really rule out, but it's designed to highlight probable NASH condition. And I think in that way, it's different from many tests we're currently seeing and applying. The combination with additional testing, it generates costs. So I think that has to be rational to do that. But by combining these strategies in a world where I could just pick my best test, this could be something to enrich. It enriches again and it increases your pretest probability. So I think then you have to look what you end up with your follow-up or sequential test. But for sure, it impacts it greatly. Yes.
And I noted also in the paper that you talked about sensitivity but not specificity, which I think speaks to this exact point, right? That what you're doing is a better job of figuring out who you need to look at further, not who you don't need to look at further.
Absolutely.
And then now what? I assume that you and others will find other databases or more work in these databases, as Kris and Louise have both pointed out, there are issues around ethnicity, et cetera, and that over time these models will improve. This is pretty darn good, but they will improve, or we will understand better how to moderate them for different kinds of populations to the degree that's needed. Maybe the most cost-effective solution to improving positive predictive value is going to lie in this kind of machine learning modeling as compared to coming up with a whole bunch of tests. I mean, you talk to Sunil Hasmain, as we did last week and will next week, and he'll tell you that the blood markers are going to get to some really good PPVs within the next 2 to 3 years. But in advance of that, and maybe as a prior step to that, if you take machine learning, and that does a pretty good job of identifying who might be at risk, and then you put it up against something with good negative predictive value, that might be a cost-effective way to screen, or to identify and screen at the same time. Chris, I see you nodding. Does that work? I always get sheepish when I do these kinds of conversations because you guys treat patients and I never have.
No, I think that's exactly what we need to do. And I think you've summarized it perfectly, which is you want to use an inexpensive, easily available, and relatively hassle-free tool to increase case finding of people at risk, so a sort of a less coarse filter, if you will. And then the next step will, of course, be the imaging-based or some other based modality, which is limited in terms of access, expertise, and cost. So if you have a test that has a higher sensitivity and can identify patients at risk, and then you move on to the test that has a better specificity and a greater positive predictive value with a good, negative predictive value, then you've essentially done the job of eliminating those patients from further interventions where there may be risk or cost involved, and then focus your efforts on those at greater likelihood of having that. So I think that sequence is exactly what is informed by work such as this.
I'm noting we're about an hour into our conversation. Not a bad time to go to final question. Before I do that, first, Jörn, thanks for bringing this paper to my attention a month or two ago, and for doing the work, and then for coming on at what is virtually a godless hour in Germany and being so clear and crisp in terms of being able to describe what's in it and stay with it. It's a great paper, and thanks for the explanation. And Kris and Louise, thanks for wonderful questions. It's been a great conversation.
Thanks. And of course, I want to highlight all co-authors and first author collaborators, sponsors here. This has really been a team effort. In case I haven't said that at this point, this is something that came out of a good group that had a lot of fun thinking about it.
You've made that clear. In fact, about the time that you disclaimed your knowledge of how the statistics happened beyond the black box, it was clear that there were other people who were doing an awful lot of help and had a big piece in this. So that's great. Final question to everybody. Something you heard today that really surprised you, and I'd like you to tie that to whether you see an overarching message from this study and these results. Kind of the ultimate so what? Brave one, go first.
Okay, I'll be foolish and brave. What surprised me was the fact that there appeared to be not much lost in terms of the robustness of this model in going from a fairly well-curated, extremely well-phenotyped population of patients with a very high NASH prevalence, not just NAFL, but NASH prevalence, and then apply that to another cohort where, in fact, the majority of the patients did not undergo liver biopsy, and a large number of those patients were characterized as at risk using these criteria. But when you look at the number of patients who did have a biopsy, it's still, over 1,000 patients. And the fact that with, I'm sure, limitations and caveats, which Jörn will acknowledge, and the paper does quite well in terms of its limitations, the fact that there's this level of transportability tells me that we can do pretty well with these models in terms of applying them to somewhat agnostic populations and not necessarily lose a huge amount in terms of getting to very low sensitivity and pickup rates of patients at risk. So to me, that was the biggest takeaway.
I think obviously the AST coming out so high was of great interest, but what struck me was when the team went to the larger data sets, you didn't gain too much additional information. So the smaller data set of 12 points makes that more applicable to a primary care and real life situation where you're not going to have to replace too much data to find that population with a high probability. And that to me keeps it real. It keeps it manageable, because if we start to go to data sets of 24, people just are less likely to implement it. And I think it's finding patients and it with the highest probability, and that's the key. And I think that interested me from that, and that surprised me.
Yeah. So as an author, if you're fortunate enough to be able to present, you're always defensive, and I guess when you present to peers, in particular Kris and you guys, you tend to be very defensive. And the comment that Kris made in saying that this is a real life database that allows some uncertainties with regards to data capture, but it still separates it so well. Feedback to me that I think it's darn good in identifying those patients. And you don't want to overstate your findings as an author. That's always difficult, in particular if you're talking to potential reviewers. But I think it was developed robustly, and it holds true, as Kris mentioned, in a diverse, much more diverse, less well characterized population with large data sets. So I'm looking forward to see it perform in other ethnicities and of course potentially other U.S. data sets.
So Jörn, first I want to thank you for that comment, because when I was asking questions about the statistics, it wasn't to challenge. This all makes a considerable amount of sense to me. So if you felt challenged, then that wasn't the intention. The intention was to say, all right, so what can I glean from this that might not have been self-evident? AST over ALT, importance of protein. But the idea that each of those things on some level becomes a marker for a bigger issue. So then what are the big issues and what are the big issues not? I hadn't, as I said, really thought until today about this idea, and you showed me this paper, I think, a month ago. I hadn't really thought about today until in the context of improving positive predictive value with tools that are readily accessible today and don't have to go through FDA approval or any of those things. Because admittedly, we don't have agents yet, but we still need to treat patients. And if we can do it efficiently and effectively with reasonable confidence that we're talking to the right people, this is a good thing. So I had not thought before today about looking to these kinds of models for the positive piece of prediction, but that makes a considerable amount of sense to me. And having seen your results even more so, that's where I think it's going to find where I think the overarching message is. With that, let me bid all of you folks adieu. Kris, Louise, thanks for great contributions. And Jörn, thanks for sharing this paper and for walking us through it from so many different directions. I think this will wind up being one of the better or more exciting episodes we've done on this podcast in a long while. Thanks all of you. Welcome to the business section of Surfing NASH. There isn't that much to report on this week.
Planning for the 4th Global NASH Congress keeps moving forward.
Last week, I reported who will be joining us for the 4th Global NASH Congress, which is next week now. Louise Campbell, Sunil Hosmain, and I will be present for the entire event. Manal Abdul-Malik and Jörn Schattenberg will be with us on Wednesday, April 28th. Naeem Al-Khoury and Ian Rowe will be with us on Thursday, April 29th. And as it looks now, Manal, Naeem, and Ian will all join us for the wrap-up that we'll post on May 5th. Starting later this week, latest the weekend, we will be posting the presentations we will cover on LinkedIn, Facebook, and in emails to our subscriber list. If you want advance notice in your mailbox, send your email address to questions@surfingnash.com and we will add you. Finally, roughly 300 of you have downloaded our preview episodes last week. We used a different format for this preview than we did for NASH-TAG or EASL or AASLD last year. I welcome your feedback on how you liked it. Please rate the episode on the website, send a message to surfingnash.com, or join the discussion in LinkedIn or Facebook.
Next week, we will start an experiment designed to enhance content.
Next week, we plan to record a session Monday, even though we will not release it for a couple of weeks. We believe that with more time, we might be able to provide a better podcast, better conversations, and possibly add some other voices and insights to the whole dialogue. I will have more on this concept in 2 weeks at the end of the Global NASH Congress wrap-up episode.
The listenership story remains a big yawn. Let's skip it.
I agree. It's all fine, so let's just move on. I want to thank Louise, Jörn, and Kris for such a great conversation, Mike for taking material from a Tuesday recording session and getting it posted the next night, and, as always, Eric and Polly for the things they do every week. Thanks to you folks for the 600 downloads during the past week and the kind words. In particular, I want to thank everyone who was at CLDF in Scottsdale who complimented our work, thanked me for what we were doing, or, crazy, even liked my voice, comment I never expected to hear in my life and heard more than once. Next week, we're posting daily, same-day episodes from the Global NASH Congress Wednesday and Thursday. Hope you'll join us, and until then, stay safe, surf on, bye-bye now.
Thanks for listening. Have any questions for the surfers? You can send them to questions@surfingnash.com, and we will answer on the podcast or the website. Have any comment to share? Join the discussion on our LinkedIn and Facebook Surfing the NASH Tsunami discussion groups. See you next week with a cast of 7 at the 4th Global NASH Congress on the Surfing the NASH Tsunami podcast.